Well, I'm delighted to be here. I didn't know there was so much to cooperatives outside of food co-ops, group health, and health partners. I also didn't know that lava tubes had to fit into the equation. I'm an allopathic family medicine doc originally from Minnesota. I don't think we have any lava tubes in Minnesota. But at any rate, Minnesota is the state of two seasons, winter and August. And I see there are a lot of contingents from Wisconsin here. You must have at least 3 seasons there, I would think. At any rate, I bring you greetings on behalf of HRSA's administrator, Dr. Mary Wakefield, and the Office of Rural Health Policy Associate Administrator, Tom Morris. My goal today is to provide you with a HRSA and an ORHP, Office of Rural Health Policy, perspective regarding some of the issues surrounding long-term care and rural seniors. A number of other initiatives exist in non-HHS departments, such as the Department of Transportation, as well as in other HHS divisions, such as the Administration on Aging and SAMHSA, the Substance Abuse and Mental Health Services Administration, but I'm not going to speak about these today. I do, though, want to serve as a facilitator. I certainly don't know all of the grant programs in HRSA or in ORHP, and I don't know all of the policy issues related to long-term care in rural America. However, I can be your contact to put you in touch with policy folks and with grant project officers at HRSA so you can get the information you need to hopefully help with some of your collaborative work. I do have some business cards here, and I'll give you my contact information later as well, so feel free to contact me either by phone or email, and again, I can work you into the appropriate system to get more information if any of what I say piques your interest. One caveat, of course, the opinions expressed here are my own and don't necessarily reflect HHS or federal policy. Paul mentioned earlier the Rural Wisconsin Health Cooperative, and I don't know if you know that CDF made the Eye on Health newsletter from February. We get this in the office, and I find it personally very thought-provoking. There's some straight policy line things, but also some think pieces and some great cartoons. So anyway, I encourage you to look at their website and to sign up for their email newsletter if you don't already have it. And again, CDF is nicely featured in the February issue. I'm going to start by talking a little bit about rural and primary care workforce challenges. And again, this is just sort of to set the context. We all sort of know this, but again, just to give a little framework to some of this. The Association of American Medical Colleges, their Center for Workforce Studies, predicts that in the next decade, there will be 45,000 too few primary care physicians, as well as a shortage of 46,000 surgeons and medical specialists. While about 20% of the U.S. population live in rural America, only about 10% of physicians practice in rural locations. In 2005, there were 55 primary care physicians for every 100,000 people in rural areas, compared to 93 per 100,000 in urban settings. There are also fewer medical school graduates that are choosing to enter primary care. In 2009, about 42% of family practice residencies matched with U.S. medical school graduates, compared to 75% in 1996. Now, fortunately, this has improved a little bit. I just noticed that the National Resident Matching Program results came out last week, and this year there were 11% more of U.S. medical school graduates who matched in family medicine residencies, which again is the physician specialty most likely to practice in rural areas. And this 11% increase is on top of another 9% increase from last year. So it's good to see the trend ticking upward again a little bit, although this still represents only about 1/2 of the available slots. There are about 2,700 family medicine slots, and again, about half of those currently are matching with U.S. medical school seniors. And of course, there's similar trends in terms of workforce challenges with physician assistants, nurse practitioners, and the gamut of healthcare professionals, and some of the others you heard from already today. A lot of this is being driven by a growing and aging population, as well as an aging healthcare workforce. So again, lots of challenges for all of us to continue to deal with. A little bit about rural infrastructure. Healthcare delivery, as we all know, is challenging in rural locations where patients tend to be poorer, sicker, older, and have less health insurance than their urban counterparts. And this is, of course, well known to all of us, and including HRSA. Not all rural communities have availability of long-term care services such as assisted living or skilled nursing, retirement housing, Meals on Wheels, home health services, hospice care, etc. Home health services in rural and frontier areas are variable. High-end therapy availability, adequately trained workforce, and transportation travel issues are a few of the many challenges. Care transition is also challenging. So the patient falls at home, transfers to the city for care, returns home. Who provides and coordinates the support needed for continued rehab after the patient returns home? Now, there are a lot of informal cooperative type home care models that already exist, in my opinion, and I'll give you an example from my hometown of 1,300 in rural Minnesota. Actually, I exaggerate. I hear the population's up to at least 1,600 now, although I haven't been there in several years. But I'm an only child, and my dad passed in 1995, and my mom lived alone for most of her remaining years until a couple of years in the local skilled nursing facility. But she lived at home in the only house that her and my dad lived in after they married. And she got a lot of informal help. My dad's grade school, high school, and golfing buddy for 50-plus years would bring her mail every day. The grocery store was only 2 blocks away, but as she got older, she couldn't walk to that anymore. So she would, they would deliver the groceries for her at no charge because it was, like on the way home for one of the staff each evening. One of her good friends for many years, after they'd go to church together on Saturday nights, they would go out to dinner every Saturday night unless there was a snowstorm for years. And on and on. A block away from where I grew up, there were 2 elderly widows who lived across the street from each other, and they had it worked out. Their bedrooms faced each other across the street, and they worked it out that the last thing they did at night and the first thing they did in the morning was draw the bedroom shade. And so if one morning one of them didn't move the shade up, the other one would know that something was wrong. And sure enough, one morning, one didn't draw the shade up, and the other woman this sort of predates the 911 calls, so she called the police, and they came by, and unfortunately, the woman had passed during the night. And so there are all sorts of these stories. One of my uncles who lived in the big town of Freeport, Minnesota, of 500 people, about 15 miles from where we were, one of his very good friends, a fellow business owner in this small community, lived a couple doors away, and when he started to show signs of Alzheimer's disease, Joe would go to his house at least 3 afternoons a week for a couple of hours so that this person's spouse would be able to get some respite care and go and do her errands, etc. So again, all these informal networks already exist in a lot of areas and such, and so although the needs are dire, again, there's a lot of ownership in these communities and a lot of networking that we all know already exists that I think we can try to draw on as well. So these informal models can be formalized utilizing the strong community networking and social infrastructure that often exists in rural America, where obviously many people wear many hats. I'm going to talk a little bit about some of the federal policy issues through the years that continue to resonate with us in HRSA and at the Office of Rural Health Policy. One of the things that we think has been, or at least I think has been particularly beneficial, has been the swing bed concept, which began in 1980. And here, of course, post-acute skilled care in rural settings can be provided in swing beds, which are inpatient beds that can be used for either acute or post-acute care as needed. The intent is to increase access to post-acute skilled care for rural Medicare beneficiaries and to maximize the efficiency of small and rural hospitals. I just saw some data actually in preparation for these remarks from 2008, and currently 90% of critical access hospitals offer swing bed services, and other rural hospitals, which are not the critical access size, they're a little bigger than that, but they're still less than 100 beds. Those hospitals offer these services at a rate of 39%. Also, 42% of critical access hospitals offered skilled nursing care in 2008, as did 30% of larger rural hospitals and 20% of urban hospitals. And finally, another statistic, 35% of critical access hospitals and 45% of other rural hospitals offered home health care services in 2008 compared to 25% of urban hospitals. So again, some of the care has been at least helped by the Critical Access Hospital Program across rural America. And of course, the Critical Access Hospital Program was authorized by the Balanced Budget Act of 1997. Are you folks all familiar with critical access hospitals? You know about the criteria and all of that? They're small hospitals. They can be 25 beds or less, and they have to have at least some 24-hour emergency department services available. They're often not, obviously not going to do your cardiac cath and all of that, but they have to have at least fundamental emergency department services available 24 hours a day. They're in general 35 miles from the nearest hospital, although there are some geographic variations depending on location, but in general 35 miles from the nearest other facility. And for acute care, patients are limited to no more than 96 hours per stay. And of course, they receive cost-based reimbursement for the most part, so their reimbursement rate is better than the typical inpatient prospective payment system reimbursement. But again, there are limitations to up to 96 hours only. So again, the swing bed concept is very important for a lot of these hospitals to help with the post-acute care for their patients. The Balanced Budget Act of 97 also authorized the PACE program, the Program of All-Inclusive Care for the Elderly, which is a permanent model of care within Medicare and also enables states to provide PACE services to Medicaid beneficiaries as a state option. And ORHP was actively involved in the early days in the early part of PACE. In the early 2000s, the National PACE Association hosted a meeting to discuss the notion of moving PACE into rural settings. ORHP subsequently issued a contract with the National PACE Association and the National Rural Health Association to promote the PACE model around the country. This led to an increased stakeholder interest and finally to CMS in 2006 providing $500,000 to 15 organizations for a rural PACE demonstration. And I frankly, I don't know a whole lot about the PACE initiative, although I do know that there has just been issued a report to Congress regarding the rural PACE program, and you can go to the NPA website and download that there if you have a particular interest in this initiative. And again, their report to Congress has just been issued, apparently. Also, to help try to keep some of these rural hospitals open, there have been some Medicare-related initiatives, and so there are some rural hospital classifications that vary from site to site and geographic area to geographic area that help enhance payments. Obviously, the critical access hospitals are one. There's also designations like sole community hospitals, Medicare-dependent hospitals, and larger rural referral centers, which again all help to impact at least elder care in general prior to the home care needs. There are also some provider and facility enhancements regarding federal policy to try to help with, again, the workforce challenges that are out there. Their Medicare Primary Care Incentive Program, which is a new ACA initiative that began in January of this year. Their Medicare bonus payments to providers practicing in geographic primary care HPSAs, health professional shortage areas. And again, some facilities besides critical access hospitals also are able to have cost-based reimbursement arrangements. These are things like the federally qualified health centers, the community health center program, and rural health clinics. So again, other federal initiatives to try to help with the challenges of elder care in general. Also, critical access hospitals and sole community hospitals as part of the ACA are now eligible for the 340B drug pricing program, and participation results in savings estimated to be 20 to 50% of the cost of pharmaceuticals for safety net providers. Now, a little bit, this is probably, there are a couple of things I really want to emphasize for you folks, and this is one of them, some specific grant programs that we in the Office of Rural Health Policy have that potentially could work with some of your other cooperative efforts to help with the development of home care elder cooperatives and other cooperative arrangements in rural America. So again, some of these programs have the potential to complement some of the cooperative solutions that you folks are discussing. And again, ORHP provides the internal federal voice for rural health policy to HHS and to Congress. And ORHP defines health rather broadly to help address the wide-ranging and community-specific healthcare needs across rural America. And a lot of our grants are 3-year grants, and they're basically seed money grants with the ultimate goal of developing regional and local sustainability. And again, as Robin and others have mentioned today, that's becoming more and more of a challenge with the state budgets being what they are. But again, the hope is that regional and local collaborative ventures can help with sustainability after these grants run out. And ORHP has, again, I'm just going to highlight a couple of them. One is one of the hospital state programs, which relates to the rural hospital flexibility grants. Now, this wouldn't be quite as primarily related to you folks, but again, just to give you some more background, these particularly support the critical access hospitals. And there are 3 main arms to these grants. They help with quality improvement, with operational and financial improvement for the facilities, and the development of collaborative regional and local delivery systems. So again, if you have a critical access hospital in your community, you might want to check with some of the staff there to see what, if anything, they might be doing related to this collaborative regional and local focus. These rural hospital flexibility grants, the flex grants, go to states actually, and there's state coordinators that are involved. But again, your local network might have some ideas to cooperate with you as well. I want to talk mostly about a couple of programs on the community-based program side of ORHP, and one are network planning grants. And this is one area that you folks might want to try to piggyback into. These grants can be used to start cooperative ventures, and hopefully there'll be a competition in FY 2011. Again, the competition, of course, depends on whether or not Congress appropriates money, and so we don't know that yet at this point for this particular year what amounts of money will be appropriated. But again, there is hopefully a competition will be planned this year for the network planning grants. And it's anticipated that there will be 12 new awards. These are limited to a maximum of $85,000 a year, and they're only 1-year awards. These are just to initiate the planning process. So again, I noticed in terms of one of the handouts in your materials related to starting a rural home care cooperative, well, there's no reason why you couldn't try to use network planning money to help with that process, to help convene your stakeholders, et cetera. So it could directly tie into that process. And so again, that's one program to emphasize. There are also network development grants, which are the next step. And the network development grants try to help create the infrastructure. And again, there's a competition plan for fiscal year 2011, hopefully with 20 awards anticipated, and here the average award is $180,000 a year for 3 years. Now these are 3-year awards, so you can use a network planning grant to kind of get the ball rolling, if you will, and then apply for a network development grant to try to go the next step for 3 years, and then work on the sustainability as well. And this is a little bit more formalized in terms of the network development side. I think, if I remember correctly, I have some information over at my desk, and if people want more specifics, I can go into that later. But as I recall, there are 3 distinct network entities that have to be involved for the network development grants, and they all have to sign, something like a memorandum of understanding or similar legal document to sort of bind them together for this process. So it is a little bit more formalized than the planning grants, again, and it is for 3 years of money. So again, that is definitely something I think that some of you folks may be interested in. Now, the network planning and network development grants don't fund direct healthcare services, but another program does, and those are our outreach grants, which can definitely be used to start a home healthcare kind of initiative or other kind of initiative. And again, I have more information if people want that later. But these definitely help increase access to care and can provide direct services. Now, there's not going to be a competition in 2011, but there is one planned for fiscal year 2012 for the outreach grants. And it's anticipated that there'll be approximately 100 awards, up to 100. These are a little bit staggered. It's usually 150,000 for the first year, 125,000 for the second year, and $100,000 for the third year. So they go down a little bit over the 3 years. But again, so hopefully there'll be somewhere around $15 million left for that competition next year. There are also there's some other ones, again, that don't directly apply to you, but again, just to help frame some of the things we're trying to support in rural America. There's another program called the Small Healthcare Provider Quality Improvement Grants, and these focus on dealing with chronic care issues like diabetes and cardiovascular disease specifically, and I think the third arm that's going to be started with the next phase is obesity as well. But there won't be any new competition for this for the next couple of years, planned now for fiscal year 2013, actually. But again, another program that tries to deal with some of the chronic care needs of rural America. And another interesting program is telehealth. There are telehealth network grants. And again, I don't know the specifics of who's eligible here, but there were just a competition this year for about $2 million, and there are 26 new awardees. And 9 of them are focusing on the cost effectiveness of telehome care. So telehealth services, and again, particularly related to congestive heart failure and diabetes in terms of home monitoring and those kinds of things. So there's that possibility as well. So those particular grants, some of them, again, I tried to emphasize would be of potential interest and cooperative ventures with you folks as you move your cooperatives forward. And the other, for those of you who have more of a policy bent and specific policy interest in some of this, I'll remind you that HRSA in the Office of Rural Health Policy supports a National Advisory Committee. It's the National Advisory Committee on Rural Health and Human Services. And all of these reports are available on the HRSA website. And the 2010 report, which just came out, has a very nice chapter on home and community-based care for rural seniors. So it's about a 10 or so page with a number of references, a document, and the advisory committee has 21 members with a multitude of expertise related to rural health and other areas. It's not just clinicians and healthcare providers of one kind or another, but people who have legal and financial backgrounds as well. And again, it's a very nice chapter on home and community-based care for rural seniors in the most recent report. So again, for those of you who are interested in other ideas and what other programs are out there, I point this out to you as well. There was also a 2006 report that discussed family caregiver support of the rural elderly, and they gave a number of examples there that I thought were very unique. And again, so for food for thought for some of you folks, you might be interested. Anybody here from Georgia? That 2006 report talked about the mobile daycare program, which I personally was fascinated with. It's where not clients, but staff move from community to community, and they go to one community a couple days a week and another community, et cetera, and they help provide some respite care and community support for elders, and the staff moves. It's not clients and such, so I found that to be particularly interesting. And another report that, again, may be of interest to you is the 2000 report, and in there's a chapter on serving the rural elderly, and that has a little bit more detailed discussion about some of the programs in other areas like administration on aging, for instance. And so most of these reports, again, are a little bit more, they'll talk about Medicaid initiatives through CMS, some Medicare-related materials. They'll talk about PACE. They'll talk about administration on aging. They'll talk about some, again, unique programs to specific areas such as the Georgia program I mentioned. And so again, for those of you who want some more food for thought or some background policy, I point those out to you. And again, if you're interested, you can let me know. They're all directly downloadable as PDF documents from the website. Again, I have cards here if you're interested in learning more about any of this. I also can put you in contact with a specific project officers involved with some of these other grants if you want to get some other information and such. And again, I greatly appreciate the opportunity to visit with you, and I wish you the very best in your efforts, and thank you again.